All right, we're going to start because it's 8 a.m. and we want to make sure we get through everything. Thank you for coming on the last day, 8 a.m. We appreciate you. My name's Aaron Lacey. I'm from Washington, St. Louis. This is Alex Bracey from Albany, and this is Ryan Barnacle from Brown. And we're going to talk about intubating today and what is some of the most modern evidence for intubation. So Alex does work for Powerful Medical as well as gets some consulting fees from Verathon. Ryan and I have no disclosures. And we are going to use a couple brand names in this, but that's mostly just pointing out the history and different types of laryngoscopy and are not an endorsement of a specific product. We're going to talk about evidence available for video versus direct laryngoscopy. We're going to talk about hyperangulated versus standard geo. And then we're going to talk in the end a little bit about using Airway as a QI methodology. So I think it's important to think about airway management, not just in 2025, but in the past as well. So where were we? So in the 1700s, they just trached everyone. They actually couldn't look at the cords. There was no technology for it. There were no bulbs. There was no way to look at it. So they just trached everyone. And then in around 1900, they invented the first laryngoscope, and then nothing changed for 100 years. Same geometry, same blade. But then in 2001, the glide scope came out. And what they did is they actually invented two things at once, both hyperangulated and video at the same time. And it wasn't until 2008 until standard geometry video laryngoscopy came out, and it was not readily available in emergency departments until around 10 years ago. And so when you think about the history of airway management and why there's so much controversy going on, is that really our modern laryngoscopy has only been around for 25 years, after hundreds of years of doing it the same way. And so with that, I'm going to hand this off to Ryan, who's going to talk about, now that we're in 2025, where are we now?
All right, so where are we in terms of the question of video laryngoscopy versus direct laryngoscopy? I don't know about everyone else in this room, but I am so sick of this question and this debate. I don't want to talk about it anymore. This is the last time I'm going to talk about it ever, okay? Fortunately, in the past year and a half, we have now evidence that hopefully I think puts this to rest. So in the mid-2023, the device trial came out, New England Journal. This was basically a pragmatic, multi-center ED ICU randomized trial, okay? Now, each arm, VL and DL, had about over 700 patients, and 90%-ish, a little over 90%, were performed by residents or critical care fellows, so trainees, so relatively inexperienced intubators. Some people call that a limitation. I call that the facts of life. But the interesting thing about this trial is it was stopped early. So they were aiming for 2,000 intubations, and they stopped at 1,000 intubations because there was such a difference in outcomes. So at 1,000 intubations, the safety board recommended stopping the trial early because 85% of the VL group had a first pass success rate and 70.8% had first pass success in the DL group. There was also basically a 19.3 or 14.3 absolute risk reduction in using VL. There was also a decrease in number of complications in the VL group. And some people kind of cite that there was some heterogeneity in terms of the blade type, the setting, but I think that is a representation of how we intubate in the emergency department now. So this is sort of the best evidence we have that VL is superior to DL in terms of randomized controlled trials. However, since this trial came out, there's been two larger systemic reviews in meta-analysis. This first one was last year in Critical Care Medicine, which incorporated the device trial. This was 3,981 patients. And again, VL was favored in almost all markers. So in terms of first pass success, in terms of glottic view, in terms of esophageal intubation, and aspiration risk, VL was superior. One thing I would like to note in this trial is that they actually looked at brands, and so they kind of came to the conclusion that not every brand is created equal. GlideScope and CMAC performed superior to other brands compared to DL, which I think is important when you're kind of trying to, at an individual site, individual program, improve your first pass success. You want to pick the right equipment. This second meta-analysis expanded even more. I think kind of they came out a couple months later, and there were some even more single-center trials that they included. And so this was in critical care medicine. Again, many of the same conclusions. So this was 4,569 patients. They basically concluded that it increases first-pass success, it decreases esophageal intubation, it probably has uncertain effect on hypoxemia rates, probably no effect on mortality, but they did note also decrease in dental injuries, which was different from the other meta-analysis trial. So the evidence is there, and I think there will still be some naysayers. But those people need to recognize the writing on the wall. So guidelines are changing. And so if you're going to go against kind of the trend, you need to know that. And so all of these guideline groups, including Difficult Airway Society, Canadian Airway Focus Group, the European Society for Emergency Medicine, and the Project for Universal Management of Airways are all recommending video laryngoscopy in critically ill patients. As a sort of preview, the ACEP is working on a clinical policy related to intubation, and they are going to be commenting on the use of VL. So this isn't out yet, it's embargoed, I can't go into details or anything like that, but soon even our own kind of groups are going to be commenting on the use of VL. There's still some stubborn arguments that you're going to hear, I think. And so if I've convinced you and you want to go back and talk to your naysayers, here are the things that I routinely hear. What if I go somewhere where there's no VL available? Well, VL is basically universal in emergency departments. And if you're in some critical access hospital that doesn't have one, there's handheld devices that you can buy yourself and bring. And I think with those benefits that we're seeing, that's a reasonable thing to do. What if there's a soiled airway? Won't it obscure my camera? We know that if you enter the airway slowly, even with a VL device, your camera is far enough back that it's not going to be soiled, even if your blade tip is in the contamination. And what if my video screen shuts off? And I included PMID numbers for all these references. Technical errors in kind of the modern devices are very rare. And what if my view is better, I accept that, but what about tube delivery? So now we know that with video laryngoscopy, the second component of intubation, which is actually delivery of the ET tube, is superior. It's not just about the glottic view. And so I think armed with these arguments, we kind of know where the things are headed. The reality is that laryngoscopy, VL versus DL, is just a small part of a much larger discussion about airway management. And so we need to make sure we're doing all of these things. But one single decision that I think remains is, if we're going to do VL, what should we be doing? Standard geometry or hyperangulated?
Thanks, Ryan. Hey everybody, I'm Alex Brazy. I'm going to talk about standard geometry video laryngoscopy versus hyperangulated video laryngoscopy. I'm going to shy away from saying HAVL, but that's like a term that's coming out, so people know. I kind of hate that. But importantly, video laryngoscopy is not a monolith. People have since the advent of video laryngoscopy been using these terms, video laryngoscopy as a non-categorical thing, typically meaning hyperangulated. But really, there are two different approaches here with regards to video laryngoscopy, even a third if you count fiber optic. But first introduced was hyperangulated video laryngoscopy with the intention of making the views better, so as to assist with intubation, particularly for difficult airways. In 2008, standard geometry video laryngoscopy was invented with the intention of improving views for easy intubation in difficult airways. So they're both the same thing, or intended to do the same thing, but importantly, they have a very different technique. Hyperangulated is intended to improve view by coming from underneath the glottis, and it requires rotation of a tube with a rigid stylet in order to enter the glottis, as opposed to Mac blade, which takes advantage of the typical direct laryngoscopy techniques. So we're talking about vectors here ultimately. Standard video laryngoscopy does the same thing that DL does. It requires lifting force. It's a physical procedure. You're intending to be able to see the glottic structures and put a tube into that with a straight line. That's not the same thing with hyperangulated. You get a great view, you're coming from underneath, but you have to rotate in order to get into that glottic structure. Well, that's great, but which is better? We've got some retrospective data here. This is, by the way, this is probably the best evidence that we have in our emergency medicine literature, and this is a retrospective review from the NEAR database, enormous cohorts. But it's limited in the fact that this is a retrospective database review, and if any of you have ever participated in something like this, you know that sometimes memory can be a little fuzzy. Or when you fill out the documentation 15 minutes, an hour, 2 days, whatever it is later, it's not exactly clear what was going on in that moment. Did that blade actually leave the teeth, did it not? In any case, in this very large retrospective study, non-randomized trial, there was no difference between the use of standard geometry video laryngoscopy and hyperangulated. What about in a different setting? This is the next kind of like level of evidence that we have. Not our setting, but an OR. In the OR, where they're undergoing surgeries in these otherwise perfectly selected patients, is there a difference between hyperangulated video laryngoscopy and standard geo? Well, in terms of first pass success, no, but in terms of glottic view, maybe, yeah, there's probably better glottic views with hyperangulated. So in a subset of patients, now this study, another NEAR database study that we have from our literature, this is not specifically geared towards the question of is hyperangulated better than standard geometry. They just happen to record those two subsets of patients. And in this cohort of trauma patients, was there a difference in first pass success between these two devices? Again, I hope I've convinced you that you can predict the answer here. The answer is no, there's no difference in first pass success. That kind of brings us to the question of like, okay, maybe this is just the wrong question. Maybe the wrong question. Maybe is there a population that might benefit from it? And of course, I think you can all make the natural leap to say, well, maybe in a circumstance where we don't have to manipulate the cervical spine as much, maybe there's a difference here. In these two systematic review meta-analyses of non-specifically ED patients undergoing endotracheal intubation, there is less cervical manipulation with anything that's not standard geometry device. That includes hyperangulated. That's kind of led to ultimately culminating in a recommendation that's come, as Ryan alluded to, the societies are making recommendations for the use of laryngoscopy. Now, I want to point out in the top red box there, they're specifically going out of their way not to comment on is standard geometry video laryngoscopy superior to hyperangulated, because you can't based upon what's available. But they do go out of their way to say, hey, we should be using video laryngoscopy in the setting of somebody who's got cervical injury. So I think it's not a terribly big leap to say, hey, maybe those with cervical injuries should undergo hyperangulated video laryngoscopy when they're being intubated. Oh, and by the way, make sure you take the anterior collar, anterior portion of a rigid collar off, or open the collar. That's the other kind of thing I wanted to point out, just because, man, it's key and to see it all the time. That kind of leaves us with this very confused looking person here. Where do we go with this? Should we be doing standard geometry? Should we not? Or should we be doing hyperangulated? Does not matter at all. We're going to answer this question, hopefully. There is an ongoing study here in the top one, the InvaBlade, which is going on. It's an RCT ongoing in Spain right now, results forthcoming. And the angle trial is in the planning stages. So we will get an answer, but it's not going to be for a while. So unfortunately, you all are left with my take. My take on this is hyperangulated and standard geometry video laryngoscopy are two very different skills, two equally important skills, because of the current landscape of where video laryngoscopy is. This becomes doubly important if you work at a place like I work, where there are trainees. You have to know how to use the device because you don't know where you're going to go work and you don't know what equipment is available to you. So I think that standard geometry video laryngoscopy should be used in all medical intubations. That is to say, there's no suspicion of trauma, and I'm implying that there's no suspicion of cervical spine injury. And I think that hyperangulated video laryngoscopy lends itself to the trauma bay, where you get your reps on the rotational force of the tube and getting that perfect view, but maybe having difficulty passing the tube otherwise. But all of the things that go into a hyperangulated video laryngoscopy attempt in trauma, or of course those with very high suspicion or known cervical spine injuries. Well, that's where we are with hyperangulated versus standard geo, but where are we going?
Okay, I'm going to bring it home, hopefully. So there are some questions that we have to answer still. So hyperangulated versus standard geometry, there's still people who are trying to figure out if we should use bougies or not based on how you interpret the data. delayed sequence intubation versus rapid sequence intubation. There are things that are coming that we don't have answers to yet, and we're gonna always see technology advance. Like articulating bougies, cheaper, more ergonomic equipment that's gonna become more available. And when you think about what Ryan talked about earlier in optimizing your success for airway management, there are many, many things. But I think one thing that you're gonna see in the future and where we're going is that both of these things are based on thinking about the pre-procedure and then the intra-procedure. And we know that if we want to get better and improve, how do we use post-procedure planning and thinking about the airway to become better? So based on what randomized control trial you look at and in what setting, the first attempt success rate around the country in the emergency department is somewhere between 80 to 86%. But there are documented in the literature hyper-performing sites that routinely are in the mid-90s or higher. And so what are they doing different than other places? And every single hyper-performing program has an airway QI program. And they have someone whose job and title is to be in charge of airway management and QI for their institution and to help institute best practices. So if you want to take the next leap beyond just getting a video blade in your department, is you have to leverage the video device to do better post-procedurally. So using video laryngoscopy for QI and education is gonna be the next step that you have to take. Every single one of these devices can record. They can auto-record, you can click it, and most of them can now automatically upload videos to some type of cloud storage system. So in the next 2 to 3 years, there are going to be thousands of airway videos on your devices that you have no idea what to do with, but you need to use them. And if you use your videos for coaching, and if you use the video screen and talk to your trainees about video laryngoscopy, coaching alone and going through airway QI increases your first attempt success in your department by between 6 to 10%. So you can take that leap from 85% to 95% just by going through airways. You can create teaching databases where you can store these videos, label them, you can add hashtags to them, and you can search things, and then you can share these videos with your other trainees. If you're gonna do this, you have to use a standard language. You have to be able to communicate what you're talking about. And for a long time, airway management was just, what do you see? Like, what do you see? And now we know that you can go back and watch film. Some people, including these two, worked really hard to come out with an actual taxonomy of different intubation steps and errors that occur in order during the process. And so therefore, when you watch a video back with a trainee or yourself, you can go through and say, these were the problems with this airway. This is how you can improve. And we underestimate how important it is to talk about our airways and share them with other people. And now this is possible with video. So have airway corners, share your procedures with other people so you can improve. So if you want to take the next step, video review is gonna be how you get there. So think about your department, think about what you're doing with your CMAC or your GlideScope or whatever device you have and how you're gonna use those videos. And so some take-home points. Video laryngoscopy is new. Like it feels like it's been around for forever, but in the grand scheme of things, and in the literature, it takes 8 to 10 years for literature and practice to all catch up. We're still finally, I think, crossing the threshold to where video laryngoscopy is everywhere, but there's still unanswered questions. The evidence supports it that it's far superior though. Academic societies are on board, so if you are talking to people or thinking about not getting on board, you're gonna be going against your own society's recommendations. So probably start to do a little reflection in the mirror if you don't wanna get on board. We're gonna know the answer to SGVL versus Havel soon. That's gonna come out in the next year. And use this for QI. And continuous QI of looking at your videos and talking about airway in your department is how you get to become a high-performing site. And I would love emergency medicine to become a high-performing specialty and not just have isolated sites. That is all we have today. We had a short time period, so thank you guys so much. Happy to take any questions.
That was great. Nice work.
Oh, thank you so much.
Yeah. So you didn't talk too much about having camera on the side, like one of my fiber optic,
Yeah.
or like using the two of them at one time.
Yeah.
What do you think about?
You want to comment on your
I should point out every kind of like modern device like throughout any of the companies is capable of doing this. There's really like three major companies and they could all do it on the monitors. But so split screen technology exists. And I think that with regards to like a fiber optic is this thing that we always talk about as emergency doctors. We're like, yeah, look, this is in our wheelhouse and we totally know how to do it. And then when push comes to shove, when it's like, all right, time to intubate this person who's got a very, very scary airway and they're awake intubation and here's the fiber optic, we're like, I really haven't done this too many times, right? I think the advantage of having the split screen technology is it allows you to plug a blade into the camera and the fiber optic, and then you can use the blade to see, are you going to be able to ever intubate this person orally or not with a like RSI technique? And if the answer is, or you can plug the blade in and then ride the fiber optic over that, and it creates a conduit, and you get to see where that fiber optic is in time and space. Using the advantage and like familiarity of a blade. So that whole technique is called like video assisted fiberendoscopic intubation, or VAFI. Such a terrible acronym, and right for change. So please make suggestions. I'm not like clever like that, but I have a couple of examples of that in very high risk in situ patients, and it's worked super well. And I think it takes advantage of our skill set in order to do, and it takes advantage of the technology. I think it's burgeoning. And I think it will ultimately be, I hope to see it used as a standard of care for patients with like upper airway lesions, like, angioedema and like that. It's a great question, Mike.
Yeah. But the reason we didn't talk about it is because there's no evidence that
Yes,
exists
good point.
on
Zero.
it at all. So, Eric.
Yes, so
Yeah,
last
that's
year
right.
in Rams grant, we're actually looking at this specific procedure in a simulated environment. We have resident trainees attending all the way to the PGY 25 level. We're looking not only at individual skill at PGY level, but it is the procedure, this novel procedure, I'll call it. I wouldn't call it standard of care just yet, although it would probably be in our scope of practice. It's better than just traditional fiber optic. And in addition to what Gracie said about the advantages, what we've realized, going through about 40 subjects, is it also provides not only multiple views of the airway anatomy, but you can also look at the other instrument, the other device, as you're intubating. And actually having that laryngoscope blade in the epiglottis, in the molecula, allows you to actually get a little bit of lift, making it mechanically easier to pass the fiber optic camera. And so the study's closed, we'll probably be putting that data out as an SAEM polls for the airway interest group, if you guys are interested in that. And then maybe written up in a peer-reviewed opportunities for multi-site studies if you're interested. The one downside was cost, right? Why are we spending so much? Why would they open up a reflex bronchoscope on every patient we're intubating? It's hundreds of dollars. My recommendation is just have it as a backup. Take a look with VL. If you get the airway that way, great. Leave the bronchoscope closed, ready for the next patient. But have it readily available where you can open it and utilize it.
Sorry, I was just.
Any other additional geometric modification in development now? There's going to be another third modification between the two you're aware of?
So not that I'm aware of, but I think that as we alluded to, not every video scope is created equal. And that's not just brand loyalty. It's people didn't realize when they were making the video scopes, a lot of these video scopes are actually pseudo hyperangulated. So the angle when you look at them is somewhere between like the Karl Stork, it's like a traditional standard geoplate, exactly the same as the Mac blade, versus GlideScope is hyperangulated. A lot of these other brands, if you look at them, they're somewhere in between, and that's where some of this confusion comes in. So I think more standardization is probably going to come out, but there's not, that I'm aware of, a third type of blade.
Yeah, I mean, I think that like the peds pop. I'm not, by the way, not a PEM doctor, but I'm compelled to work in peds every now and again, and so they have hyperangulated. Hyperangulated again was like the original like video blade type, and it only recently kind of have they come out with like Millers that are of every single size. So I think that's kind of like one of their frontiers, or like getting these like niche sizes like a Mac 2 or Mac 2.5, like so different variations on that. And I actually think that the majority of the development is on the wire that connects to the blade itself for the purposes of like doing QI stuff and pictures and the like. So
I think that's, yeah, we'll take your question. I don't know what time the next talk starts, so I want to be
maybe never.
respectful. Maybe never. We'll just
Maybe
do-
never. There's a lot of spell calls here.
Did you see any difference between like a screen with a monitor versus just the handheld, like McGrath?
In the device trial, McGrath performed, in the systemic review of critical care, the McGrath performed poorly, or less,
Yeah.
equal to DL, less than GlideScope and CMAC.
Yeah, so it seems like the systems with the actual towers and carts perform better than the.
But I will point out that GlideScope, again, not endorsing a brand, but they have the handheld camera screen, or they have a camera screen that can attach to the same exact blade that it plugs into the tower. So the geometry is identical. It's just a much smaller screen, and those are called GlideScope Go's, I think, Go 2s. So you have the same exact camera, same exact geometry. It's just a smaller screen that attaches to it.
I think that's all the time we got. Thank you guys so much. Thanks for coming.
Appreciate it.